And today we are going to discuss patent ductus arteriosus and other congenital heart defects in this lecture. So, in the previous lecture we had done ASD and VSD. So, patent ductus arteriosus. Now, see, ductus arteriosus is the connection which is which connects the pulmonary artery to the descending aorta, and it usually closes shortly after the birth. But sometimes, when it failed to close by 1 month after the expected date of delivery, uh, like we call it as patent ductus arteriosus. Okay, like this ductus arteriosus is still patent. So uh, then, of course, like there is abnormal communication, and there is shunting of the blood again from the the left side of the heart to the left side of the circulation to the right side. Simply the oxygenated blood will go and mix up with deoxygenated blood. Now, it is like in the preterm babies, uh, this one closes a little later, by the way. Okay, so delayed closure of ductus is common in premature infants, you can say. So, which is different from the PDA in the term infants. So, now, this is the classification of PDA. You can see how they look like, but not so important, by the way. Um, Pathophysiology, again, I told you about the prostaglandin levels in the previous lecture, okay, what happens and how it closes. So, the important thing to tell about this one, um, like normally, um, as I told you, within 15 hours of life, after birth, the ductus arteriosus closes down. But uh, whenever it is not closing, especially in the term infants, then there are chances that it is going to stay, and we have to do some medical and surgical intervention to close that. So the natural history, you can say, in most of the cases, it closes spontaneously. Again, like I would like to show you some video for this one to make you understand the thing better. Uh, okay, this one, sorry, like this one is like too childish video. It is about PDA, but like this is for the babies for their education. Now, like sorry, I'm not going to show you any video for that, okay, because that video is related to PDA, but like they had made tracks or trains and stuff like this. So um, clinically, whenever the patients have PDA, so most of them they are asymptomatic. They don't show any symptoms, normal weight gain, and no special symptoms are there. So, whenever they start showing symptoms, they could be anything like poor feeding or um, congestive heart failure or anything like this. Okay, but of course, like late findings. But a very interesting type of finding which we can see in these patients is um, you can say a continuous murmur. Okay, what happens is simply when the heart go in systole, the blood flow over there, and when the heart go in diastole, the blood flow backwards. So basically, there is a continuous murmur, no matter it is in diastole or systole, the murmur will be there. So we call it as heavy machinery type of murmur. So simply we just call it as machinery, or rolling thunder in quality, or it is also called as machinery type of murmur. The pulse rate is high. There is wide pulse pressure, because if you know what is pulse pressure, because when the heart go in diastole, the blood which is stopped by the aortic wall, but now the blood have some place to escape in. So there is wide pulse pressure, and the pulse is bounding in in character, right? So when we check the pulse, the best place to hear this continuous machinery murmur is basically under the left sternal border, or under the left clavicle, under the left clavicular area. This is the area where it is best heard. So simply we can do ECG, which can show right ventricular enlargement or left ventricular enlargement. We can do a X-ray, which can show like the heart is enlarged because the heart is functioning more than normal. Sometimes, like the pulmonary vasculature is more visible. But the echo is, of course, the diagnostic test is echo. Echo will diagnose the thing. Now, see, this is like the descending aorta, and this is the PDA, the abnormal communication, can seen on echo or can be seen on Dopplers, right? So this is the thing. Now, the interesting thing is the management. Um, now, PDA have a very interesting story in this regard, that some of the heart conditions we have to keep this ductus arteriosus open. I will tell you which heart conditions. But as we are discussing patent ductus arteriosus now, what leads to the closure of ductus arteriosus? That is the decrease in the level of the prostaglandins. So, what happens uh, in the patients when the ductus arteriosus is patent? We can give them, just remember the name of one drug, that's it, indomethacin. What is this? This is a drug which basically decreases prostaglandins in the blood, or especially prostaglandin. It antagonizes prostaglandin E2. So this is the one which maintain that. So when this drug antagonizes this thing, so of course the closure occurs. And if the closure is not occurring in this way, then we go for a surgical closure. Okay. So the surgical closure is done by, nowadays, of course, like less invasive techniques are there. So of course, like closure is recommended to decrease the risk of infective endocarditis, decrease the risk of pulmonary vascular conditions, and usually the closure is done by a coil or occlusion device via a cardiac catheter at around 1 year of age. But nowadays, occasionally surgical closure is needed because medications are there and less invasive things are there. So this is about PDA. Now, before going to the cyanotic heart diseases, guys, uh, there are certain other conditions like which we say obstructive type of conditions, right? So one of the condition is called as coarctation of aorta, right? Now, coarctation of the aorta is such a topic that you are going to study that thing multiple times in surgery, in medicine, and quite an interesting type of congenital heart defect. Okay. Um, Again, I will show. I will try to show like if there is any decent video which is there, and I think I have one in my laptop, so I can play over here. Short video, but I think like
coarctation of the aorta. Coarctation of the aorta refers to a narrowing of the main blood vessel carrying oxygen-rich blood from the heart to the body.
So simply, guys, you can see like the coarctation is there right here. So this coarctation, like the blood which is leaving from the aorta, will get some what you can say narrowing or blockage, obstruction at this thing as that at this point. So that's why we call it as obstructive lesions, or for example, there is aortic stenosis or pulmonary stenosis.
The vessels before the coarctation see higher blood pressure than those after. Coarctation can sometimes be detected by differences in the blood pressure in the arms and legs. The degree of the narrowing determines how soon intervention is needed. Severe coarctation of the aorta is often found in the first few weeks of life. However, a less severe coarctation may go undiscovered for years.
Okay, one thing which I will show you about coarctation of aorta is will be on internet. Okay, and like what I would like to show is as weird things are going on, Bing is not available right now, so okay. Let's continue without that. So yeah, as you can see, like there is a narrowing at aorta, okay, and most of the time that the narrowing is at the level of ductus arteriosus. That's what I wanted to show you. And many of the times, this coarctation of aorta is basically associated with bicuspid aortic valve, like just two cusps of aortic valve is there, and it is also associated with Turner syndrome. So again, in coarctation of aorta, if the narrowing is not so severe or is not too much, the patients remain asymptomatic. But a very interesting finding, which we can see in these patients, is when we check the blood pressure in the four limbs, there is a decrease in the blood pressure depending on which level the coarctation is there. If you know the how the blood is supplied to the upper limbs, there is a left subclavian artery. So if the coarctation is before the left subclavian artery, what happens, like there is more blood pressure in the right hand and less blood pressure in the left hand, as well as in the lungs, in the legs. And if the coarctation is after um, this the origin of subclavian artery, so what happens, there will be increased blood pressure in both the right and left uh, upper limbs, but there will be less blood pressure in the lower limbs. So simply, there is blood pressure discrepancy between the upper and the lower extremities. And one more thing, we when we examine the cardiovascular system, we put our one thumb or fingers on the radial pulse, and we check the femoral pulse as well, and we see like either both of the pulses they are coming at the same time or not, because in coarctation of aorta the femoral pulse is delayed than the radial pulse, or something which we call it as a radiofemoral delay is there. Of course, because of coarctation the blood goes slow towards the femoral artery. So that is the thing, and sometimes we can hear a murmur as well. It's a systolic murmur, which is best heard in the left axilla. So, uh, of course, in severe type of coarctations, like even in the neonatal period, the signs and symptoms started appearing. ECG again is diagnostic, and the patient can present with right ventricular hypertrophy or left ventricular hypertrophy. We can do a echo. We can do echo is diagnostic, and we can do ECG. We can do MRI and other investigations as well. Now, what is the management of coarctation of aorta? what we do, we give them prostaglandins in this case. So see, that's what I was telling you, that why this one is interesting. So in coarctation of aorta, we give them prostaglandins to keep the ductus arteriosus open or patent, to stabilize the condition and perform a surgical correction in neonates. Okay. And in older children or infants, we can do balloon arterioplasty. We can pass a balloon and take it to the coarctation, and then inflate the balloon and like dilate that area. So same thing with aortic stenosis, with pulmonary stenosis, of course. These are the patients who have like obstruction to the blood flow is there, right? So and of course, when there is what you can say obstruction to the blood flow, so how the patients will present, they will present with the same sign and symptoms how they present with coarctation of aorta or with other obstructive lesions or conditions. So if the obstruction is not so severe that you will not find any symptoms, or the patients will be asymptomatic, but whenever the obstruction is severe, so the patient can present with congestive heart failure, chest pain. Of course, the babies cannot tell the chest pain, but if the baby is a little bigger, like more than like 5 to 6 years, they can tell. Many of the patients, they die because of sudden deaths in aortic stenosis, especially because the heart cannot supply enough blood to the body. So uh, in cyanotic heart conditions, the most common or the most important one to study is tetralogy of Fallot. Okay. So of course, like, this is cyanotic heart condition, and I told you how to remember cyanotic heart conditions is 5 T's with, and after that you can remember Epstein's anomaly, or you can remember left hypoplastic heart syndrome. And what is going on in cyanotic heart conditions? Basically, the systemic venous return re-enters the systemic circulation, and that's why there is cyanosis, because the oxygen saturation is less. Okay. So one of the tests which we do in these patients, is a test called as hyperoxia test. Okay. Hyperoxia test is done in these patients. So what is this hyperoxia test? Like, this is to help to determine, uh, like whenever there is cyanosis, remember, it could be a heart condition, it could be lung conditions, it could be metabolic conditions, it could be other conditions. So this hyperoxia test is used to, or it helps to determine the presence of heart disease in cyanotic patients. Okay. So what we do, like, the infant is placed in 100% oxygen box or ventilator, you can say, uh, for around 10 minutes. Okay. So if the right um, arterial pressure of oxygen, like we do ABGs, arterial blood gases. So if the right arterial oxygen level, uh, you can say, remains low, okay, we make a diagnosis of cyanotic heart condition. Okay. Because if there is a lung disease in these patients, okay, and when we are giving them more and more oxygen, so of course, like, the oxygen level should be more, right? And if the oxygen saturation increases in the right radial blood, so of course it is not a heart condition, rather it could be any other condition. So this is the important thing, like, or hyperoxia test, to differentiate, like, either the cause of the cyanosis is a lung condition or a heart condition. So um, uh, what is tetralogy of Fallot? Um it is the most common cyanotic heart defect. Basically, to tell you the exact thing about the commonality of this condition, this is the most common cyanotic heart defect. Okay. Most common cyanotic heart defects diagnosed beyond what you can say infancy. Okay. Now, why this thing is important? Simply because I will tell you one reason behind this thing. Um, Tetralogy of Fallot overall is the most common cyanotic heart defect. Okay, cyanotic heart defect. Okay, but the patients who have a tetralogy of Fallot, okay, uh, they don't become cynos right after birth. Rather, they become cynos after the first 1 month has passed, and the peak is around 2 to 4 months of age. So, you know what is the definition of neonates? Neonates, we call them neonates until the first month of their life or first 28 days or the first 4 weeks, right? We call them neonates. And up to 1 year of age, it is infants. So, basically, this condition is not diagnosed during neonatal period. Rather, it is the most common cyanotic heart condition of infancy. Like after first month of their life, we get diagnosed this condition. The most common cyanotic congenital heart defect in neonates is transposition of great arteries. Rather, I should write this point over here to make you remember this thing. Okay, so remember the most common cyanotic heart condition beyond what you can say infancy is tetralogy of Fallot, whereas the most you can say the most common uh, what you can say cyanotic heart condition or congenital heart disease in neonates is um, transposition of great arteries. Okay, transposition of great arteries is there. So a very important thing that what is the pathophysiology of this condition is uh, you can see over here. By the way, I will show you one video, like the things will become quite easy for you. There is right ventricular outflow tract obstruction, and to like the tetralogy of Fallot have basically four major you can say uh, things, okay, or defects, like how we diagnose. Okay, so that's why it is called as tetralogy. Okay, tetra. So basically, this one have that's why it is called as tetralogy of Fallot, because it have four big like defects which are there, and that's why this is called as that thing. Um, Now I will show you the video, and that the video is going to give you a good insight of the condition, how the condition looks like. Okay, so you can see over here.
Tetralogy of Fallot repair. This is a view from inside the right ventricle. Pulmonary outflow obstruction is relieved by resecting the infundibular muscle. A patch is used to close the VSD.
So see, the first defect is basically a VSD. Okay, so one thing which in these patients have is a VSD. The second thing which these patients have is right ventricle outflow tract obstruction, which means the blood, the outflow, like the blood which goes out from the right ventricle, which is of course from the pulmonary valve, is basically have obstruction. So the third thing is there is overriding of aorta, like the aorta overrides and the VSD. And the fourth feature is right ventricular hypertrophy. So see, they are closing the VSD.
The pulmonary artery is opened, often across the pulmonary valve. Additional muscle causing pulmonary outflow obstruction is removed.
So what is done here, see, like they are removing the obstruction which is offered to the blood at the pulmonary valve. So they are removing some muscles from there to open it.
A patch is used to further expand the pulmonary outflow tract. Pre-repair, post-repair. With the VSD closed and the pulmonary outflow tract open, there is no longer shunting or obstruction to cause cyanosis, as noted by the separation of red and blue blood in the post-repair.
See, in this one, a lot of mixing is going on, right? In that one, there's no mixing going on. Okay, so basically what is going on in these patients, you can say 4 things are there. Number 1 thing is what? There is obstruction to the pulmonary artery, right? Or right ventricular outflow tract obstruction. Second thing, there is a VSD. Third thing is what? There is overriding aorta. Like normally the aorta should open, like should be originated from the left ventricle, but if you will see over here, the aorta is moved a little towards the right side, so there is overriding. The aorta is not receiving the blood from the left ventricle, rather from both left and right ventricle. And you can see the normal, there is no mixing, but here you can see this purple stream. It means there is mixing. The oxygenated as well as the deoxygenated blood, they are mixed together, and a less oxygenated blood is supplied to the rest of the body. So there is a lot of mixing going on in this one. So this is like the 4 features. And right ventricular hypertrophy, which occurs in Tetralogy of Fallot. So now, of course, it's an embryological defect. Okay, and how the patient present? The patient don't present right after birth. Rather, they present, like the peak age of presentation is around 2 to 4 months of age. Now, what I will tell you is how the patient present is basically something called as hypoxemic spells, or they are also called as it's TET spells. Okay, the patient present with TET spells. The patient present with TET spells. So these are hypoxemic spells. What happens uh, when the patient is in some exertional state, like the baby is crying, okay, what happens, or exercising? There is increased pulmonary vascular resistance and decrease in systemic resistance. So whenever this is the thing, basically there is an increase in right to left shunting. So for example, when the baby is crying or exercising, the systemic vascular resistance is decreased, so more and more blood from the right ventricle will enter into the aorta. So more, the body will get more and more deoxygenated blood. And how the patient will present? He will present with a cyanotic spell, and we call it as TET spell. Okay, so the clinical features of this condition is basically uh, there is paroxysms or episodes of rapid and deep breathing, irritability. The child become irritable, they cry, okay, and basically which increases the cyanosis. So uh, this is the thing. And of course, like if the condition is severe, like this is a TET spell, see, they become cyanosed, see the tip of the nose and see the lips. So if severe, it can lead to decreased level of consciousness as well, sometimes seizures and even death. So when we examine them, what we found is we found a loud S2 murmur. S2, remember, is caused by the closure of the aortic as well as the pulmonary wall. So of course, like in this one, there is severe pulmonary stenosis, so there is a loud S2 sound, okay, which is best heard at the left sternal border. As well as there could be systolic ejection murmur, because when the heart is going into systole, it will push the blood out from the heart, and it can lead to systolic ejection murmur. So this is how the patient presents. Now there is TET spells is there, right? The important thing, guys, to talk about in this one is anyone who have tetralogy of Fallot. Okay, the child can have one of the clinical feature can be clubbing. Okay, so how we diagnose them? Remember, echo is the diagnostic test because it will tell you the structure of the heart, what are the defects, and all these things. You can do chest X-ray, and when you will do chest X-ray, basically the heart is boot-shaped heart. See, it looks like a boot. Okay, so there is a boot-shaped heart in chest X-ray. Um, so uh, Of course, that thing is diagnostic. Now, how we manage these patients, okay? Basically, before going to surgery, we have to manage these spells, okay? And how to manage the spells is basically we put the baby in knee chest position. And what this knee chest position do, basically, it decreases the resistance and decreases the mixing of the blood. So simply the initial management is medical, and of course that like surgery is the definitive management, but surgery can only be performed around 4 to 6 months of age. So like until waiting for that age, what the surgery do, as you can see, they will close the VSD, they are going to open the obstruction, and they will patch it, okay. They will put artificial patch in VSD and also in the pulmonary artery to make it big. So when the children are cyanosed, when they are exercising or crying, uh, due to increase in pulmonary resistance, uh, what happens, like, there will be a TET spell. And like when the children are very much cyanosed, okay, of course, like we decide, okay, that there is, like, it's a time to do surgery, of course. So basically these cyanotic spells are usually self-limiting, right? When we, especially when we put the child on in sleep, or when we put the child in this position, knee chest position, uh, sedation and pain relief can be given. For example, we can give the babies morphine in these cases. We can also give the babies beta blockers like propranolol. Okay. So what propranolol do is basically it's a peripheral. Uh, we can also give propranolol. We give to the babies. What it does, like, it causes peripheral vasoconstriction. Okay, so when there is peripheral vasoconstriction is there, there will be increased systemic resistance, so less mixing will be there. Okay, sometimes we have to give them IV fluids as well, to increase their volume, and they may have acidosis, so we can give them bicarbonate. So like this is how we treat them. And the name of the surgery which is done is, like, I show you that thing. Okay, so nowadays, of course, like this can be completely repaired by surgery. Okay, so like surgical repair is done, of course, for these patients. Okay, there is a surgical placement of a shunt or an artificial tube between the subclavian artery and the pulmonary artery. This is called as Bell-Tossic shunt. Okay, or sometimes we can use a balloon dilatation as well to dilate the pulmonary artery in these patients. So this is like what is the management of these patients. And see, you can see the clubbing of the toes in this baby. Okay, so the treatment can be palliative, like again by giving beta blocking agents, IV fluids, a morphine, and total correction can be there. So of course, like previously, like there were different surgeries which can be done for these patients. So guys, like this is the most common one, most important one. And believe me, like if any question, like if you will sit for any exams, like most of the questions come from these topics. uh, Transposition of the great arteries is, as I told you, it is the most common cyanotic heart condition in the neonatal period, right? And what is the transposition of great arteries is basically, um, I can show you the videos just to make you understand the conditions, okay, and how they are like how they present, right? You can see over here.
And goes to the body via the aorta. In transposition, blue oxygen-poor blood returns to the body through the right atrium, enters the right ventricle, and goes to the body via the aorta, bypassing the lungs. Red oxygen-rich blood is pumped back into the lungs via the pulmonary artery without going to the body. As a result, newborns with TGA are born with a bluish appearance, known as cyanosis. In TGA, there needs to be a connection between the right and left sides of the heart so oxygen-rich blood can reach the body. Most commonly, this occurs between the atria, or upper chambers of the heart. This is inside of the right atrium. In a normal heart, this hole is closed to separate blood in the two upper chambers. A patent foramen ovale, or PFO, is a partially closed connection between the top chambers. An atrial septal defect, or ASD, is a completely open hole between the top chambers. In TGA, there needs to be an ASD or PFO so that oxygen-rich blood can reach the body.
So see, like this is again one more condition because see there is transposition of the great arteries, and practically in the body there is two parallel circulations are working, like the systemic circulation and the pulmonary circulation. The blood from the body is coming into the right atrium. From right atrium, it is going to the right ventricle, and from the right ventricle, it should go. It should go to the pulmonary artery, but in this case, it is going to the aorta and then back to the body. And the other circulation, the pulmonary blood which is coming from the lungs enters into the left atrium, and from there it is entering the left ventricle, and from there it should enter aorta, but in this case it is entering into the pulmonary artery and going to back to the lungs. So simply the oxygenated blood is running into a different circuit, and deoxygenated blood is running into a different circuit. So how we can make the patient survive? Of course, we need a VSD, a ASD, or a PDA, so that the mixing should be on and the patient can survive. So this is one of the case in which we give prostaglandin E1 infusion to keep the ductus arteriosus open, okay, until of course the surgical repair is done. Okay, so this is one of the condition in which we have to keep it open until the repair is done.
In order to establish normal blood flow, surgery is needed in the first couple weeks of life. This involves switching the aorta and pulmonary artery to their normal location.
Oh, so this is about transposition of great arteries. Remember, guys, the ECG appearance, the X-ray appearance is X-shaped heart. Echo is diagnostic, and the rest of the points I told you. Here comes the total anomalous pulmonary venous return. Okay, which I show you. It is not so common, but 1 to 2% of the congenital heart defects, it can be there. And what is there, like all the pulmonary veins, it drain into the right-sided circulation. Okay, so, and of course, like there is no direct oxygenated pulmonary venous return to the left atrium. So when all the blood coming from the lungs is going into the left right atrium, so in the systemic circulation, of course, will not get any oxygenated blood. So this is the problem in this case. So ASD or atrial septal defects must be present for oxygenated blood to shunt into the left atrium. Okay, and then of course to the systemic circulation. And the management again remains the surgical closure.
Total anomalous pulmonary venous return, TAPVR. TAPVR is a congenital defect in which the pulmonary veins do not connect normally to the left atrium. Normally, the pulmonary veins return oxygen-rich blood to the left atrium. Instead, they drain oxygen-rich blood to the superior vena cava by an abnormal or anomalous connecting vein. This results in oxygen-rich blood not going directly to the body. This is a view from inside the right atrium. This is an atrial septal defect, or ASD. An ASD is a hole between the top chambers of the heart that allows oxygen-rich blood to enter the body's circulation. Blood flow in TAPVR. Here, oxygen-rich red blood enters the pulmonary veins. Then it mixes with oxygen-poor blue blood in the superior vena cava. Some of the mixed blood supply travels through the ASD into the left atrium. Babies with TAPVR will need surgery within the first few weeks of life.
Okay. After that, there comes truncus arteriosus. And what is truncus arteriosus? Again, in this one, basically, there is a single great vessel that give rise to the aorta, pulmonary, as well as the coronary arteries. Okay, so instead of like multiple, there is a single great vessel. So there is VSD as well, and of course, like when this is the case, there is potential for the coronary ischemia. Okay, and like surgery should be done in the first few weeks of life for the survival. You will understand this thing when you will see this video.
Truncus arteriosus. Truncus arteriosus refers to a common trunk that includes both the pulmonary artery and aorta.
A common trunk is there, which is giving rise to everything.
A hole, called a VSD, between the bottom chambers allows blood to mix before entering the common trunk. The mixed blood then goes to the body and lungs. To the body, through the aorta. To the lungs, through the pulmonary artery. As the baby ages, the blood pressure in the lungs drop, resulting in too much blood going to the lungs and causing congestive heart failure. Surgery is necessary to separate the pulmonary artery from the aorta.
Okay. Then comes the hypoplastic heart syndrome, and again, it is like it is the most common cause of death from congenital heart defect in the first month of life. It is the most common cause of death from congenital heart defects in the first month of life. And what happens in these patients? Like there is four features of hypoplastic left heart syndrome. There is hypoplastic left ventricle, There is narrow mitral as well as aortic valve. Remember, it is left heart syndrome. So see, everything is related to the left heart. Hypoplastic left ventricle, narrow mitral and aortic valves, small ascending aorta, and there is coarctation of aorta. So the management of this thing is again to keep the ductus arteriosus open. We give them prostaglandin E1, and of course we either prepare for the surgery or heart transplant.
Hypoplastic Left Heart Syndrome, HLHS. The term hypoplastic refers to underdevelopment of a tissue or organ. In HLHS, most of the left-sided heart structures are hypoplastic.
See this one.
This is a view from inside the right atrium. An atrial septal defect, or ASD, is a hole between the right and left atria. This is a view from inside the left atrium. The mitral valve is also hypoplastic and is either severely narrowed or not formed at all. The abnormal mitral valve prevents blood from entering the left ventricle. Blood flow is then diverted across the ASD and into the right atrium. Blood returned from both the lungs and body flows into the right ventricle. The right ventricle pumps blood to both the lungs and the body. This is why HLHS is referred to as a single ventricle defect. In HLHS, a PDA exists to provide blood flow from the pulmonary artery to the body. Babies with HLHS have a bluish appearance, known as cyanosis, as a result of mixing oxygen-rich and oxygen-poor blood. If the PDA closes, the baby will become critically ill. A continuous IV medication called prostaglandin is needed to keep the PDA open after birth. Surgery is typically performed within the first few weeks of life.
Okay, guys, so the last one which I include, I said Epstein anomaly. So, what is Epstein anomaly is basically, of course, like when you will see the video, you would know the main features, but there is basically a valve malformation in these patients, okay? And this one is associated with the use of certain drugs like lithium and benzodiazepines. So, lithium is used to treat many conditions like mood disorders. So the mothers who are taking this during their pregnancy, their babies can have Epstein's anomaly. So you can see this video and it will give you a good insight about Epstein anomalies.
Epstein anomaly. Epstein anomaly refers to a defect of the tricuspid valve. The tricuspid valve separates the right atrium from the right ventricle. The tricuspid valve is displaced into the right ventricle. This is inside the right ventricle. As a result, the septal leaflet is tethered and the anterior leaflet is enlarged. The abnormal valve can lead to backflow of blood, referred to as regurgitation, into the right atrium. In Epstein anomaly, the right atrium is larger than normal. There is typically a PFO or ASD. Patent foramen ovale, or PFO, is a partially open hole between the top chambers. Atrial septal defect, or ASD, is a completely open hole between the top chambers. This is blood flow in Epstein anomaly. Here is blood shunting across the ASD. This is tricuspid valve regurgitation. Tricuspid regurgitation and a small effective right ventricle can lead to heart failure.
So how we treat these patients is by like in Epstein anomaly, we like repair the tricuspid valve or close the tricuspid valve. Sometimes transplantation can be done. In older children, we can repair the tricuspid valve, or we can replace the tricuspid valve and close the ASD. Okay, guys, one thing which I was telling you, remember the end result or the extreme result or the extreme consequences of all these conditions can be congestive heart failure. Okay, whenever there is congestive heart failure, so remember, uh, like the heart has failed, so the features will be more or less like what happens in the adult. So talking about the causes of a congestive heart failure, what we are studying now is congenital heart defects. They can cause congestive heart failure, as well as anemia can cause congestive heart failure. um, Hyperthyroidism, okay, can cause congestive heart failure. um, Sepsis can cause in babies congestive heart failure. And when I say congenital heart defect, basically it have aortic stenosis, it have coarctation of aorta, it have pulmonary stenosis, and all these things. Of course, they come under this thing, and many more causes are there, of course, which can lead to congestive heart failure. Now, the important things to understand here, or to remember here, how the babies present. The babies, they are weak, they become irritable. Okay, they have feeding difficulties when they have heart failure, and when like the babies are big. Okay, one very important thing is like sweating. Okay, especially while eating. This is a very very important clinical point. And they have lethargy, as well as there you will find failure to thrive, right? So when the children, when the baby is like, it's a child who can walk, so they have decreased exercise tolerance. Okay, they cannot tolerate, or they cannot play like other kids can play, and they complain a lot of fatigue all the time. They have decreased appetite. Remember, like the blood cannot be supplied properly to different parts of the body, so almost every part of the body will be affected. So they have decreased appetite, they have respiratory distress, uh, they have more and frequent upper respiratory tract infections. We can also call it as cardiac asthma. And of course, like same like adults, they will be having pedal edema. Okay, or what you can say, paroxysmal nocturnal dyspnea during the night, right? So same things. When we do their physical examination, remember, two tachys and two megalies, so they can present with tachypnea and tachycardia. Okay, the same like adults, as well as there will be cardiomegaly and plus hepatomegalys. Okay, hepatomegaly will be there. So we can found these features. You can found like growth chart abnormalities or failure to thrive features. Okay, all these things are there. So again, investigations, guys. Chest X-ray can show cardiomegaly. You can go for echo. You can go for EKG or ECG. Okay, ECG will show sinus tachycardia and all these things, and you can do like other blood workup, to see anemia is there, so you can do CBC. Thyroid is there, so you can do thyroid function test. So same like these things. Okay, sepsis is there, so you can do so on and so forth. All those things. So and the treatment is again same. Uh, Sodium and water restriction if there is edema, of course. Okay, in the patients, and simply we give them diuretics like adults. Okay, we give them ACE inhibitors, which basically decrease the afterload. We can give them beta blockers. Okay, and digoxin can be given but rarely used. Okay, in the pediatric setup, but we can use, and of course, like treat the underlying cause if you found any. So I hope you understand. I hope you enjoy this lecture. Okay, though like it was quite an unprepared type of lecture, but that's all about the congenital heart defects, what we have to study in pediatrics.